think we might have this one out of order. Check. No, that's okay. We'll go ahead. So it's a pleasure to introduce Dr. Daniella Bianchi-Frias, who is a researcher here at Fred Hutch. The next two talks are really going to focus on minimally invasive or non-invasive ways to characterize features of prostate cancer without needing a biopsy, for example. So there are some maybe we could find, I didn't see your slide on here. Maybe they're out of order. Just a second. We'll try to find them. This one. Okay, great. So there's a lot of excitement of being able to use urine as a source to find key features of prostate cancer, and then also looking at blood-based assays of circulating tumor DNA and circulating tumor cells. So Daniella's work has focused on developing better ways to identify aggressive prostate cancer in the urine, and she'll give you an update on that.
Thank you. It's a great honor to be here and present to you. And what I would like to do in the next few minutes is to give you a flavor of what are the urinary tests for prostate cancer and why we are ended up trying to use urine tests and the value of these tests in diagnosing prostate cancer as well as the value in prognosis. So typically the risk stratification for prostate cancer is based on three parameters, which are the clinical stage, the serum PSA, and the Gleason score. And the Gleason score is assigned by the pathologist based on how your tumor cells look like in the biopsy. And what I want you to take a note here is that if there is any Gleason pattern 4, already the risk of cancer aggressiveness increased. And typically, the typical options for an intermediate and a high-risk prostate cancer is going through surgery or radiation. But when there is a low-risk prostate cancer, these are men with a Gleason score 6 or lower and low PSA. There is also the active surveillance, which is monitoring the patient without any treatment until you see evidence of disease progression. So this is a randomized trial at the UK where they randomly selected patients to go through the 3 management modality for localized prostate cancer. And they were randomized to a surgery, radiotherapy, or active monitoring. And what I want you to appreciate in this graph is that 99% of patients over 10 years of follow-up have a prostate cancer survival prostate cancer survival. So this is irrespective of the tumor, of the treatment or the management of this localized prostate cancer. However, the same group demonstrated that in the active monitoring group, there is actually disease progression and metastasis over time, over the 10 years of time. And so what this graph is showing is one, that there is 80%, about 80% of patients that could have safely been monitored through like active surveillance of active monitor without any risk of developing the metastasis. But most importantly, what this is showing is that there is actually 20% of cases where they were presented with a presumed low-risk disease, but it actually had an occult high grade, or that the disease progressed and became more aggressive. So there are limitations for active surveillance, and as it has been previously shown, so there is a prostate cancer heterogeneity, and the other, like the limitation on active surveillance, is the undersampling of these like foci of high grade tumor in the biopsy setting. So, and we know, like for example, if this man in the biopsy might be presented with a low-grade cancer, but then at the radical prostatectomy, they would be upgraded due to these non-sampled high-grade foci. And we know that there is actually between like 20 to 36% of patients that when go through radical prostatectomy, there is an upgrade of the Gleason score. So the researchers, what we have been trying to do is come up with some biomarkers and that will recapitulate what we observe in the prostate, but considering the heterogeneity. So the idea is to have like serum markers, tissue markers, or urine markers, and specifically with the urine markers. So the idea is to capture the heterogeneity of the prostate and get all the cells in the urine stream. So how this is works, so this is the prostate again, this is a different cartoon. And so prostate cells, both like normal cells and cancer cells, are shed into the urine stream. And then the tumor cells, as well as the normal cells, are collected in the urine. And the first urine test that was developed is called the Progensa PCA3 urinary test. And this is based on the expression of a PCA3 gene that is specific for prostate cancer. So what you can see here is the idea is that the urine sample is collected after a digital rectal examination, and it is sent to a laboratory where the laboratory extracts the RNA and measure the number of the count of this PCA3 mRNA. And it will give you a score. And this is, so what it means is like a high score of the PCA3 means that there's more probabilities that when you go under a biopsy, there's going to be a cancer in your biopsy. And if you have a lower score of PCA3, there is less probabilities that you will find a cancer in the biopsy. So there have been several studies that have shown the useful of the PCA3 in biopsy negative elevated PSA cases. And so it has been shown to reduce the necessary first biopsies as well. However, there are like a lot of conflicting data where regarding the relationship of this PCA3 test and the aggressiveness of the tumor. And in response of this, there are several researchers that have suggested to use different markers in combination with the PCA3 in order to improve the prognostic value. So in this table, I'm showing is like the urine biomarkers available today, and the commonality of these tests is that all of them use the technique, the mRNA level of a specific molecule, either specific molecules that are associated with prostate cancer, like PCA3 and TMPRSS2-ERG, and other molecules, genes that are associated with the cis aggressiveness, such as the HOXD6 and the LX1. And due to like time, I'm just going to focus on the select MDX assay, which is actually the assay that is giving the most value on predicting a high-grade tumor. So this is the results that are obtained with the select MDX. And what this does is measure the expression level of these two genes, HOXC6 and DLX1. So if you have high expression of these two genes, there's higher probability that you will have a high-grade prostate cancer. And it is reflected by likelihood percentage. So these are results where there is a likelihood of 85% having prostate cancer upon biopsy. And within this percentage, 50%, there's a likelihood of having a high-grade tumor compared to a 35% of having a low-grade. So you can imagine that men with a high-risk disease will benefit of having an early urinary test that will suggest to go through biopsy and prove potentially aggressive treatments. But on the other hand, men with a low risk of having prostate cancer might benefit on avoiding the initial biopsy and continue monitoring through like a urine test until there's a sign of there's a higher chance of having a prostate cancer. So this test, it looks promising. There's still a lot of work to do. So in the last scientific report using these two genes, they found that they improved on unnecessary biopsy by 42%. So 42% of men didn't require biopsies. However, there is still a 2% of misdiagnosed high-grade prostate cancer. So there's still a lot of work to do, but the results are encouraging. So in overall, for the urine biomarkers that are available today, so they have most of them has shown that it reduces unnecessary biopsies and probably overdiagnosis of prostate cancer. And potentially, I didn't talk to you about this, but potentially the combination of the urinary marker combined with a traditional clinical risk factor must improve the patient risk stratification. And however, the main challenges still exist, that we're still missing some cases where there is a high-grade disease. So now I'm gonna, in the final minutes, I'm gonna give you a flavor of what is done in the laboratory setting and a basic research. And we're still working really hard on this because what we want is to move this line up to here so that we don't miss any patients with a high grade or high risk disease. And on the other hand, maintain the other patients without any intensive intervention that will be safely monitored. So the objective of the studies that I've been working on is to identify urine, Gleason-associated, the expression of genes that are associated with a high Gleason prostate cancer. And the hypothesis that I have was that if these genes are detected in urine, they will reflect a high-grade prostate cancer. So the way that I started this study was dissecting. So this is the histology of a prostate. This is a benign cell. These are the tumor cells with a Gleason pattern 3, and these are tumor cells with a Gleason pattern 4. And what I did was capture these cells and then extract its RNA, and then do gene expression analysis and say which genes in this setting of a Gleason pattern 4 are upregulated, and can I detect them in urine. So I come up with a panel of 49 genes that are highly expressed in Gleason pattern 4 prostate cancer. And as to remind you, if there is any pattern 4, the risk increase. So these are some results using tissue prostate cancer. And what I'm showing you is 3 different cohorts where a GIP6 score, which is what I am calling this 49 gene panel. So when you have a GIP6 score, a high GIP6 score means that the probability of having a high-grade prostate cancer increased. And what I want to show is these are Gleason 6 and Gleason 7 in 3 different patient cohorts. And in all of them, there is a significant increase, that there is higher GIP6 score in the high-grade prostate cancer. And moreover, this GIP6 score, the patients that have a GIP6 score higher than 0, there is more biochemical recurrence. And this is shown in these 2 graphs in the red line. So, but this is in tissue, and the question is what is happening in the urine? Can I really identify these markers in urine? So these are some preliminary data, and what I did was take 4 of the genes that are in my GIP6 panel and identify, ask if they are really able to have a high sensitivity and a high specificity of identifying a high-grade cancer. And what I'm showing you here is each of these colored lines are each gene separate. And in the black line is the 4 gene panel. And what I want you to see is that combining different genes, there is an improvement upon the prediction of having a high-grade tumor. So this is also some preliminary data where I have the urine the urine samples. And something to take in mind is that these samples were taken from patients that went through radical prostatectomy. So I know exactly what is the Gleason, the pathological Gleason score. And what I found is that in these patients, these are the definitive Gleason score in the radical prostatectomy. There is a higher GIP6 score with the higher the glycine. And moreover, and more important, is that the patients that were upgraded from a biopsy to a radical prostatectomy, there was a higher DIP-6 score on those patients, but not on the patients that have no upgrade. So I want to just to take in mind, keep in mind that these are all preliminary data. This is a very small cohort. There is still a lot of statistical analysis to do and a lot of more cells, more samples to analyze in order to have a conclusive data. But just wanted to give you the flavor of what I'm doing at this moment. So in summary, there is truly, if there's a low risk, a truly low risk prostate cancer, there is no risk of metastasis. And there might be a high percentage of patients that will benefit and avoid invasive interventions such as radical prostatectomy or radiotherapy, and will benefit from active surveillance. However, there is this, 20 to 36% of presumed low-risk cancer, low-risk patients that harbor high-grade disease, and that's where we really need to work on identifying these patients. So, but there is a lot of promise on urine biomarker. There is still a lot of work to do, and so that's where we are now. Thank you.
Thank you, Daniella.